So the topic of my talk today is, what would medicine be without risk? And I thought I would start by giving you an idea of what I do. And the easiest thing I could think of was to describe myself as a plumber, because this is what I do. When we built our pool in our house, I realized I do a very similar job. This plumber came, he looked at everything, he said to me, this pipe needs to connect to this pipe, but there's a pool in the middle. So today I'll fix the pool, and then on Monday I'll just come and do the bypass of these two pipes. I said, no, that doesn't make sense. In surgery, we would do the bypass first, and then we would do the surface. But basically, the principles in both these fields are the same, and it is, you have to have a good foundation, and that foundation always has to be scientifically well thought through, and you have to do all the baseline work correctly first. If you have these two things, then you can start talking about risk. And that's important when you listen to the rest of my talk. Now, today's medicine, the field of medicine today, is dominated by evidence-based medicine. This is the thing we teach our medical students. Think about this, think about that. We learn them to have a set of safe therapeutic boxes that they can put their knowledge into. And we learn them to teach and to train patients to do certain things which we believe are the right things to do. And this is what evidence-based medicine is. And it's based on the best available peer journals and the best available articles in the field. But evidence-based medicine, when we looked at renal failure at the end of 2005-06 and the situation for HIV-positive patients, didn't work very well. Because there was no evidence for anything. There was no evidence that dialysis would work for them. There was no evidence that transplantation would be a good option. And basically what happened was, I realized that these patients had no option. They had nothing available to them. And the reason was because we as scientists and as doctors really concentrated on evidence-based medicine, and we didn't really have evidence for anything at that point. So I started meeting some of these patients, and the first patient I met was somebody who was faced with this really bad situation. She was going to die because she was 25 years old and she had a small kid, and she was presented in the Groote renal program, and because she was HIV positive, they turned her down for dialysis, and she knew this. And it was really dramatic to see her and to understand that this woman only had a few months, if not a few weeks, left to live, and that there were actually things we could do for her. Also, I saw another gentleman. He was from Uganda. He was in a very difficult political situation throughout his life. He then came to South Africa and discovered he had HIV and renal failure and realized there's nothing that can be done for him. And he was looking at the only option left for him, namely death. But there are also patients who are HIV positive who could pay for dialysis or who could access dialysis in some other way. And I also met some of those people. So people who were financially dependent on their family to help them pay for dialysis, which was really difficult. Dialysis is so expensive. It costs about 3,000 to 4,000 rand a week to dialyze somebody. And then also if you work, it's very time consuming. So I met a gentleman. He said to me, look, doctor, I cannot actually go on like this. I wake up in the morning at 4, I drive through to the dialysis unit, I start my dialysis at 5, it takes me 4 hours to dialyze. When I get to work, I feel miserable, I feel horrible, I can't do it. And this is the truth. This is what we were facing at that stage, and this is what I had been thinking about. Can I use HIV positive donors at least to help these patients? These patients didn't qualify for anything. And I was also, as a transplant surgeon, faced with the reality of the situation where we sit with families. We tell them, we want to tell you about organ donation. Would you consider giving your families organs? They say, yes, we would love to do this. We want to do something good for the community. And when we started doing the tests, we had to go back to them and say, sorry, we can't use your organs. We can't use the family member that you've just donated organs because they're HIV positive. We're so sorry. And this was a real dismal situation, having the needy patient on the one hand, the family who wanted to donate, and this diagnosis of HIV coming in between. So I started thinking about the risk. What is the risk? The risk perceived by journals, by scientists. What is this risk? And I started reading about it. And I realized it's not very well documented. Actually, it's not documented at all. There are issues about giving somebody a new viral strain, but it's all in uncontrolled circumstances. It's in situations where people have unprotected sex. There is no real evidence for what would happen in a situation where you give a patient a new viral strain with the organ and in a controlled situation. So this was something that I started to read about, starting to inquire about with people who were working with other HIV transplant programs using HIV negative organs, which we could not do in South Africa. So basically I wanted to ask you today, what do you think is the difference between an idea that spreads slowly and an idea that spreads very fast and gets accepted very easily? This guy, Atul Gawande, wrote this wonderful article in the New Yorker fairly recently in July about what it is that makes this difference. And he uses an example. He uses, on the one hand, the discovery of an anesthetic. So this was done by two guys, Bigelow and Morton. And on the other hand, he puts the situation that Lister found himself in. Lister was a surgeon. And the two people who discovered the anesthetic published their research work in the Boston's Medical and Surgical Journal in 1846. And Lister published his stuff in the Lancet in 1867. So roughly in the same time. And the difference between the two is that the use of anesthetic agents spread like a fire. Within a year, everybody was doing it. All the big hospitals, all the big cities, everybody was doing it. Where Lister's idea of aseptic technique really took a whole century to start. So this was a completely different situation. And why was it? So the author says it's because the visible and immediate problem of pain is visible to everybody. So people want to address that. But germs, sort of, well, nobody can see it, so perhaps that's the reason. He also says life for patients would be easier if they get an anesthetic. And for doctors, it would also be easier. So for the surgeon, it would be much easier to operate and do something on somebody who gets an anesthetic. But if you look at the whole procedure that Lister proposed, the whole scrubbing with carbolic acid, it burnt the surgeon's hands. It was a whole rigmarole to do. The author says, well, he thinks it's unlikely that there would be buy-in from the doctors. It would make life better for patients, but not for doctors. Now, I as a surgeon can't really relate to that because we actually don't make any mistakes, It's just very unlikely that something would not get implemented because of the surgeon, perhaps the nurse or the assistant, If something happens, if something goes wrong in theatre, it's normally the assistant, either the head is in the way or they give you the wrong instrument. But it's never the surgeon. It's not us. But I think, Mr. Gawande can go and read another article, which I thought was very interesting when I started reading about risk. And this was published in Futures magazine a while ago, in 1993, and by Fantovic and Ravich. And basically they said that when you have a high-risk situation, when you have to do something new in a high-risk environment, it's really an issue of policy in this high-risk environment. And basically your traditional solving methods that you use probably without even thinking about it now wouldn't work anymore. So you sit in a situation which he calls post-normal science. And basically post-normal science is based on this diagram. So if you can think about my situation with the HIV-positive patients who had nothing, and I don't really have proof to say that this new virus is not going to harm them, this is what I had. It was unpredictable. The control was incomplete. There was a complex system. There were some contradictions in what people thought would happen. And if I would use traditional problem-solving strategies, it simply would not work. So you had to come up with something that will address the uncertainty in knowledge and the complexity in ethics in this situation, which is quite difficult. So the author now tells me that this is the situation, and I can go and think about my HIV transplant project in this context, and I can say, that the quality assurance in my HIV transplant project is hugely problematic and not well documented. But secondly, also that the resolution of this problem of treating HIV patients would require a completely new scientific methodology. And I think this project of mine really related to what those authors put into theory in that article in 1993. So they say applied science is mission-orientated, professional consultancy is mostly client-driven, core science is curiosity-motivated, but for me, this was an issue-driven project. There was a huge issue that needed to be addressed. So, generally in my general life, in my general day-to-day work, I cut down risk to a bare minimum. I get up in the morning, I go, I operate on a patient, take the kidney out, I put the kidney in, I give the patient the same immune suppression, the same fluids, the same drugs, I go home, I dress my kids, put them to bed, go to sleep. No risk. I never have to worry, I never have to think. It just comes naturally, and I think a lot of professional task is like this. But in the HIV situation, I suddenly found myself where this whole project and the fact that I've done some of these transplants endangered my career. Now, let me tell you what I've done. I basically stood up one morning and there was this HIV positive donor available to us. And this donor was, I knew about these 4 patients I've told you in the beginning. And this donor was certified brain dead and in a perfect condition. And I have done a lot of work on this project. And I decided to do the transplants and to just get the 2 patients in. I made them sign the consent forms. I already met with them long ago before the transplants, and I actually had them fully informed about what this would be. And I did the first 2 transplants. However, it created a very abnormal situation in the university context. And there were a lot of inquiry. There were a lot of people who were upset. There were people who said it was too high risk. The procedure was not well thought through. There were a lot of problems. And the thing is, I was in a lot of trouble already. But then, about a week and a half later, there became a second donor available. And despite having all the problems, I had in mind this woman with a small kid and this guy from Uganda, and the first donor wasn't suitable for them. And I thought, I actually want to transplant these people. And I thought, I'm just going to do it. So I went on and I transplanted another 2 patients, and this caused chaos. People were upset, letters were written, I had to go and see people, heads of departments were informed, the provincial administration was informed. I personally wouldn't be surprised if the Queen was informed. So everybody was investigating this situation. I had to go through many meetings. I had to go and defend why I did it, how I thought about it, what are the signs, what are the evidence, what is this based on. And basically, I was in a situation where I felt like a criminal, like somebody who's done something that's completely wrong, not thought through, not the right thing to do. But I have thought about it a lot. And I thought about it when I planned this, that the clinical argument was actually very easy. Because if you think about it, is the absence of evidence of harm the same as the evidence of absence of harm? And basically, I was in a situation where I thought, there is no proof, there is no answer, I just have to do this, I just need to jump in. The other thing is, who is right? If you have many involved parties, if you have a cauldron of people giving you an opinion, who is right? The thing is, it's an uncertain system, and there's a lot of ethical issues that are available in this situation. And in that, when you're confronted with a situation like that, often the hard facts, which normally dominates your thought processes, becomes the lighter thing, and the soft values become the more important thing. And in my case, the soft values was basically need. It was the humanistic side. It was thinking about the patients. It was giving them a new chance at life. And that's, in the end, what I based my decisions on. But going back to the article that I've discussed with you in Futures, that guy says when you have a system like that, a system which is so unorganized and so difficult to deal with, it's almost like having a flood. It's almost like having a flood which comes from a climate change, which then has another impact on the biodiversity, which have another impact on on climate, which might cause another flood. And basically, it's a situation which is destructive and which causes a lot of deviation. But it has an impact on a wide range of things. And for me, it was the same, because the outfall after I did the HIV transplants was not only about the transplants, but it was about the dialysis policy, about the finances, about what people thought is appropriate for HIV-positive patients, and the impact on the broader community. So that is, I think, what I had to deal with. But it put HIV-positive patients in that frame of mind where people had to think about it. What do they want? What do they need? So for you today, what is the take-home message that you can take from me as a plumber or as a surgeon? You're not all surgeons, and most of you probably won't ever be surgeons. This is not about surgery. This is an issue about risk. We sometimes have to rely on intuition. Sometimes we can't go according to the boxes that people have taught us to use. It's not often, it's probably only in 1% of situations, but we have to rely on our intuition. And when we become in that situation, we have to think, jump in and just take the risk and do what you think is the right thing to do. And if you do that, you probably will find that risk becomes your friend. Thank you.